of our academic. So we have speaker today, Dr. John Tilley, who is a Wits alumni. He completed his undergraduate training year, then went on to complete his sub-specialization in critical care. He's currently the director of the Medical Intensive Care Unit, just a stone's throw away at Donald Gordon Medical Center. He's also a lead hospitalist in oncology and bone marrow transplant. So today he's going to give us a look at hypoxaemia, particularly looking at it from a respiratory point, which, as we all know, is the most important way to look at things. Thank you, Dr. Tilley. To you.
Good morning. All right, I'm going to chat about hypoxia today, hypoxaemia more specifically. We've noticed that the registrar coming through the ICU at DG have got, as Ernie Song used to say, some haters in your knowledge. So I thought that it would be useful to go through. It's an easier, light-hearted. So let's start off. Is it fine to the side? Yeah. All right. So just to remind you, there are 5 causes of hypoxaemia. The reduced inspiratory oxygen, diffusion defects, hyperventilation, cardiac shunting, and VQ mismatch. But really in clinical practice, there are only 2 causes, because unless you are practicing medicine on Mount Everest, the reduced FiO2 is not really going to impact. The same with diffusion defects, and cardiac shunting is really a topic all by itself. So for all intents and purposes, if you see a patient and the patient has got hypoxaemia, then it must be one of 2 causes, that being hyperventilation and VQ mismatch. So it's very easy to diagnose. If we start off with hyperventilation, the causes of hyperventilation are obvious. We don't need to go through that. As opioid neuromuscular diseases, central nervous system diseases, whatever the case may be. But there's an interesting thing about hyperventilation and hypoxaemia, and this can be borne out by the alveolar gas equation. So just to remind you, the alveolar gas equation is. Do you have a pointer? No. Okay. The alveolar gas equation is basically your inspired oxygen minus the CO2 of the respiratory quotient. So if we're in Johannesburg and we plug in the values, we're going to get 627 minus 47. And just to remind you that the 47 comes from your nasal passages, which humidifies the air that you breathe in. So that's a fairly constant value. So we then subtract the 2 from that, we get our equation at the bottom. So if we then change the subject of the equation, let's assume that the patient is hypoxemia at a PaO2 of 60 over here, and we need to get the PaO2 with a big A in the alveolus. We can get that using the AA gradient. We can assume about 10. So we can plug in 60 plus 10 there, and we turn it around. So now what we can do is we can now calculate the expected CO2 at a specific FiO2 for a patient with who's got a PaO2 of 60. And the values that we get are as follows. So if you're on supplemental oxygen, if you're breathing Romero, sorry, thanks. Which way is it? So if you're breathing Romero over there, for you to become hypoxic, your CO2 needs to be 41. So these are patients that are hyperventilating. So you've got a patient who's lying in bed, they don't have any oxygen on, you've given some morphine, and by the time that the CO2 gets to 41, they will start getting hypoxic. If you've given the patient any oxygen, so if you even give nasocannula 2 liters per minute, your CO2 needs to go up to 73 before you become hypoxic. If you give 4 liters per minute, it needs to go up to 111 before you become hypoxic. And if you give 6 liters, it needs to go up to 148. So the lesson to be taken away from this is that if you've got a patient who you're monitoring for hyperventilation, and you are monitoring this by looking at the the onset of hypoxemia, you will only diagnose hypoxemia when the patient is peri-arrest. If the patient is breathing room air, you can do it, but if the patient has any supplemental oxygen, you cannot monitor hyperventilation using hypoxemia. The hypoxemia of hyperventilation is always overcome by supplemental oxygen. So that is the important thing to remember about hyperventilation and hypoxemia. Then there's the second cause of hypoxemia being VQ mismatch. VQ mismatch seems to be a bit of a mystery. You know, if you ask people what the cause of one of the causes of hypoxemia is, they will offer a diagnosis or a cause of VQ mismatch. But if we ask people to explain exactly what VQ mismatch is, then the wheels start coming off. And I think that is because in the textbooks, VQ mismatch is incredibly poorly explained. We'll try and do a bit of a better job today. So looking at VQ mismatch, we've got a normal alveolus at the bottom here, air comes in the top, and you've got blood going through. So there's contact between the blood supply and the air, and you get gas exchange happening over there. So there are basically two things that can go wrong. Either you can get a problem with your blood flow, or you can get a problem with the alveolus. So if we look at the two extremes, we've got a blood vessel here, which has become blocked. There's air going in and out of the alveolus, and there's no blood flow that's going through there. So if you have a situation like this, what respiratory problem does this result in? Any suggestions? So yeah, so this is typically what you see with a pulmonary embolus. But what gaseous defect do you see with this situation? So yeah, so the main thing is that this side of the VQ mismatch will cause the problems in your CO2, and this side of the VQ mismatch will cause problems with your PaO2. The only way for you to become hypoxemic is if blood goes from the venous side to the arterial side without making contact with air, right? There's no other way for you to become hypoxemic. It's as simple as that. For you to become hypoxemic from a VQ mismatch, venous blood must go to the arterial side without making contact with air. So if you have a situation like this where the blood vessel is blocked, that means there's no blood flow through there, right? If there's no blood flow through there, then you can't have a situation where there's blood going through the alveolar unit without making contact with air, because there's no blood flow. So the question then goes from here, if that is indeed the case, if you get a blockage of your blood vessel and there's no blood flow through there, and we said that only results in a raised CO2, how do you get hypoxic in a pulmonary embolus? You see, it doesn't make sense. They have been lying to you all of this time. The mechanism of hypoxemia and pulmonary embolus is not simple. It sounds simple when you start off, but when you start thinking about it, it doesn't actually fundamentally make sense how you become hypoxemic in the pulmonary embolus. We'll talk about that in a second. The way that you do become hypoxic is where you've got blood which goes from the venous side to the arterial side, and there's either a reduced diffusion through the alveolus, or there's no diffusion through the alveolus. So the alveolus becomes filled, and it becomes filled with things like fluid, like in pulmonary edema. It can become filled with blood, like an alveolar hemorrhage. It can become filled with cells, either a pneumonia or a malignancy, like a lymphangitis situation. But the alveolar unit becomes non-functional, and blood goes through from the venous side to the arterial side. There's no contact with air, and you become hypoxemic from that. Under normal circumstances, what should happen is that this blood vessel here should vasoconstrict to prevent blood from passing through. The lung should be fairly good at that. Unfortunately, in conditions such as sepsis, you get paradoxical vasodilation of these blood vessels, which promotes flow of blood through these units which are not functioning. So the important thing about VQ mismatches is that you can get an occlusion of the alveolus, or you can get an occlusion of the blood vessel. Occlusions of the blood vessels makes the alveolus non-functional because it cuts it off from the supply, and it effectively creates dead space. So the dead space that we are normally familiar with is is physiological dead space, in your trachea and your bronchi that are not involved with gas exchange. But alveolar dead space is when there is ventilation into the alveolus with no contact with blood flow. And this doesn't sound like a major mechanism, but it is a major mechanism. It is probably one of the main contributors to an elevated CO2 in patients with COPD. Also in patients with various lung diseases, if you put them on a ventilator, you can see that you can move air in and out of the lung quite easily, but our CO2 remains high, out of keeping with the minute ventilation. And the reason for that is because you've got occlusion of the microvasculature and you've got no contact with air. So these will all result in an increased CO2, and these will all result in a decreased PaO2. The important thing about this, though, is that if you are trying to remedy the situation over here, there's only one cause of alveolar filling that is amenable to therapy, and that is atelectasis. So if a patient has got atelectasis, meaning that these little alveolar units here have become collapsed and become non-functional, in those cases, you can try and apply a positive pressure by whichever means, either a non-invasive ventilation, high-flow nasal cannulae, or invasive ventilation to try and open up the alveoli. All other causes, be it fluid, be it cellular debris, is not amenable to therapy. There's nothing that we can do to go into the alveolus to remove the cells from the alveolus. So unless you've got atelectasis, the fact is that you would have to accept that your patient is going to remain hypoxemic, because the patient will continue to shunt to that area. And the typical thing that we see is a young patient with a strep pneumonia, where the alveoli become filled with cells. You get shunting past this area, and the patient becomes deeply hypoxic, and where you have a partial occlusion of the alveolus, you may increase oxygenation by increasing the oxygen in there. But if you've got an occlusion here and you've got shunting past this alveolus, no amount of oxygen can change this, because the oxygen can't get to the blood vessel. So in a patient who has got, say, a pneumonia, and this is the predominant issue, you have to accept the patient will remain hypoxemic. There's nothing that you can do about it. And I think that there's been, in the last few years, an insight into management of these patients in ICU. If we try and vigorously ventilate the patient, try and solve this, all that we do is we cause baro and volume trauma in the patient, but I mean, that is not amenable. The only therapy that a ventilator can apply is increasing your functional residual capacity. That is the only specific treatment modality that a ventilator can do. A ventilator can increase atelectatic units, increase your functional residual capacity, but more than that, there's no specific therapy that a ventilator can apply in the lungs. So that's VQ mismatch. It's really very simple if you look at it in a diagram like that. So this will be 99% of the problems that you see with patients who are hypoxemic. So the next question is then, how do we diagnose and monitor hypoxemia? So the first thing that registrars tell us is that we must do an arterial blood gas and we must measure the PaO2. And then I always offer the pulse oximeter, and people are somewhat horrified that you should use a pulse oximeter to monitor hypoxemia. But we've got help on the way, and the help on the way is in the form of the equation that calculates the oxygen content of your blood. You remember that from physiology. So the oxygen content of your blood is a combination of the dissolved oxygen and the oxygen bound to hemoglobin. So the dissolved oxygen is 0.003. Sorry, George, I keep on feeling that I'm pointing this laser in your eye. And then the bound to hemoglobin is 1.39 times your hemoglobin times your saturation. So if we plug in some values there, we take a PaO2 of 60, we're going to get 0.186 moles. And if we plug in the values there with an HB of 12 and saturation of 95%, we're going to get 15.8 mol. So now, if you look at this equation, I ask you, what is more important in carrying oxygen in the blood? Is it the dissolved, oxygen from your PaO2, or is it your saturation of your hemoglobin? And the answer is obvious. There's no comparison between the two values. There is limited value in PaO2 in diagnosing and monitoring hypoxemia. You can forget about it. Leave it at the door. If you're doing special indices like your PF ratio on a patient with a ventilator, in those cases you can calculate that, but that's for a different situation. But if you're just monitoring a patient, the saturation is by far more important than what your PaO2 is. And your saturation can be monitored readily with pulse oximetry. It's a non-invasive, easy thing to do. We don't need a PaO2 in these patients. If we look at blood gases, what are the problems with arterial blood gases? The first thing is obviously it's very painful for a patient to have an arterial blood gas. The second thing is that 10 to 15% of arterial blood gases are venous samples. I'm sure, as you are taught, the only way to know if a blood gas is an arterial sample is that you can see it pulsate when you take the blood gas. There's no other fancy way of telling the difference between them. If you've got a very hypoxic patient, arterial blood gases can look like venous blood gases. It's difficult to tell the difference between them. And an ABG really is just a snapshot of the patient at that time. You know, in ICU, we can do an ABG maybe 3 times or 4 times a day. So you get an update 3 or 4 times a day. A pulse oximeter is a continuum measurement of this. It's non-invasive and right there. The important thing to remember is that many blood gas machines, when they report the saturation on the blood gas machine, that is not directly measured. Some blood gas machines do that. Many blood gas machines calculate the saturation based on your oxygen hemoglobin dissociation curve. So the saturation that you're getting from your blood gas machine may not actually be a real saturation anyway. And then, not surprisingly, as with any result in medicine, your results vary. So this was a study that was done where they were doing serial blood gases on a patient, and you can see that the readings all over the place. So really, unless you've got a specific reason to be doing an ABG, that should largely be abandoned. Just to keep in mind with oximetry, there is some influence with nail polish. Then, you know, obviously with your dyshemoglobinemias, there's a problem as well. With patients with methemoglobin, often the saturation will read 85%, regardless of what you do with that. Darker skin tends to influence the reading as well. But none of these are major issues. I'm not saying that you must not do blood gases. Blood gases are very useful. All sick patients should have a blood gas. I would encourage you, unless your patient is very well, to gas every single patient. The blood gas will tell you the truth of the patient. But don't do arterial blood gases. Do a venous blood gas. If we look at a patient who otherwise looks okay, you can see that this patient, if we have a look there, there's a little bit of acidosis. The CO2 is not bad. The PaO2 is not bad. Little bit of metabolic acidosis. We come down here. All of this is looking okay. Our lactate here is 11.5. This patient is in deep trouble. And this is really the best early warning system that you've got for patients. If you've got a patient and you're worried about the patient and you do a gas on the patient and the lactate is 0.5, 0.8, 1.5, 2, then you sleep easy at night. If you have a patient, even if the patient looks fantastic at the time and the lactate is 6, 7, 8, 9, 10, you are in trouble. And it's not going to be long before the wheels start coming off. So you should gas your patients. If we look at the correlation between arterial and venous gases, the pH correlation is very good. There's a minor difference between an arterial and a venous blood gas. Obviously, a PaO2 is of no good in a venous gas. PCO2 up to 45 is basically the same. There's a little bit of a difference, but you can take the PCO2 in your venous gas to be very similar to in the arterial gas. Bicarb is basically the same. Lactate is basically the same. Base excess is basically the same. So from an arterial gas to a venous gas, you're going to get exactly the same readings, except for your PaO2, which is going to be lower in your venous gas. And as we have hopefully established now, there is limited value to PaO2 as an entity. Overall, you should just measure the saturation. All right. Now, the next thing that I want to talk about is work of breathing. Normally, breathing is a very efficient process. So you have about 5 to 6% of your body energy goes towards breathing. It's very easy for you to breathe generally. When patients get sick, the work of breathing goes up. The work of breathing can go up to 20, 30, 40% of your total body energy. And work of breathing is an important thing to diagnose. The cardinal signs, there are 4 cardinal signs of increased work of breathing. The first one is tachypnea. Tachypnea really is a very neglected vital sign. When we ask the registrar what are the vital signs, they tell the blood pressure, the heart rate, the saturation, sometimes the glucose, but nobody ever mentions the respiratory rate. When we look at a patient and the patient strikes us as being unwell, there are generally 2 things that make you think a patient is unwell. The one is tachypnea and the other one is wasting. So those are the 2 things that make you feel that a patient is unwell. And tachypnea is such an important vital sign. If you are trying to figure out if a patient is in trouble or not, and you haven't seen the patient yourself, and you're on the phone now you're saying, well, how is the patient? They say, well, the patient's looking like this or like that. You should just ask what the respiratory rate is. If the patient is breathing at a respiratory rate above 30, you're in trouble. Problems are coming. If the patient is breathing at a respiratory rate of 18, we can relax about things. So respiratory rate is very important. The odds ratios here these are odd ratios for diagnosing increased work of breathing. And you can see as the respiratory rate goes up, your odds ratio goes up dramatically. Diaphoresis is also relatively good at diagnosing increased work of breathing. But there are some other things that can cause diaphoresis, like CO2 retention. So that's not necessarily always an increased work of breathing, accessory muscle use or gasping, but these are all relatively end-stage things. Ask about respiratory rate in your patients. So the question then arises, if you had to think about it, why is it that when you start becoming hypoxic or hypoxemic, we know the difference between hypoxia and hypoxemia, right? The hypoxemia means that there's a low oxygen concentration in the blood. Hypoxic means that there's an end tissue oxygen problem. So, if you get cyanide poisoning, you get tissue hypoxia, but you're not hypoxemic. The oxygen in your blood is fine. But why is it that when we become hypoxic, we become tachypneic? I mean, why is this? I mean, there must be a reason. There must be a reason for this. And the answer to that lies in the dissociation curve. So this curve you have seen when you were doing physiology in second year. You flip through the book, it looked very nice. And then from there on, I'm sure we have paid no further attention to it. It's a sigmoidal curve. The reason why it's a sigmoidal curve is because you remember hemoglobin binds 4 oxygen molecules at a time. It undergoes something called cooperative binding. And the reason why it is called cooperative binding is the first oxygen to bind to a hemoglobin binds so with difficulty. After it's bound, there are some conformational changes that happen in the hemoglobin which open up the other binding sites. The second oxygen binds with greater ease, the third one binds even easier, and the fourth one binds the easiest. So the more saturated your hemoglobin becomes, the easier it is for it to become saturation. That gives this initial lag and then the steep curve up. So if we then look at the curve in a bit more detail, you would remember that the curve can shift to the right and the shift can shift to the left. And the way that physiology normally sells this to you is that when your lung, the curve is shifted to the left. When you get to the tissues, you drop your pH slightly, your CO2 is a bit higher and so on. The curve shifts to the right, the hemoglobin offloads the oxygen, right? And that is how you bind it centrally, you offload it peripherally. And that is certainly a fine explanation for what goes on. But the important thing to remember about this dissociation curve is that in the lungs themselves, you can shift the curve to the left and to the right, okay? So if you have a patient who is for some reason acidotic, the curve in the lung is going to shift to the right, meaning that your oxygen, your hemoglobin in the lung itself is going to accept less oxygen because you've shifted your curve to the right. So this is not just a curve that is applicable to central versus peripheral. This is a curve which is applicable in the lung itself. So if we start looking at this in more detail, we can see that as we change the pH, it changes. So for instance, let's take a PaO2 here of 40. At a pH of 6.9, we're going to get SATs of 50%. If we go up and we increase our pH to 7.56, we're going to get SATs of almost 90. Is that 90%? It should be. It feels like one of those graphs in biology where they ask you to read something off. But you can see that just by changing the pH in a patient, the amount of oxygen that the hemoglobin is able to accept changes fairly dramatically. I mean, it goes from there up to there. This is essentially in your lungs. This is not necessarily in the peripheries. We see the same thing with your CO2. As the CO2 goes up, you get a shift to the right, and you're able to accept less and less oxygen onto the hemoglobin. So if we look at aviation medicine, there are some interesting experiments that we can apply to clinical practice. So the problem that they see in aviation medicine is hypercapnic hypoxia. What happens is that you become hypoxemic, you start becoming tachypneic, and you drop your CO2. And then if we look at the studies that they have done in the Norwegian Special Forces, what they've done here is they've kept the saturation there. They have fixed the oxygen in this particular patient at the points over here have a fixed PaO2 of 41. What they've done is they then changed the C, and they've asked the change in your PaO2. Your PaO2 has stayed constant. Okay, so you have from changing your CO2 from 30 to 15, you have changed your saturation from 55 to 95 without changing any oxygenation. We have accepted that in patients that have got pneumonia or that have got alveolar units that are not working, we have accepted that those alveolar units are broken until they are fixed in time by the body. There's nothing that we can do about that. The amount of oxygen that you can get into a patient's body is fixed. Unless there's atelectasis, we are not going to get any extra oxygen. But you can see the value in tachypnea in these patients, right? So we know that PaO2 is of no consequence. So don't worry about the fact that the PaO2 is stable. We see that as we become more tachypneic and the CO2 starts dropping, your saturation goes up and your body maintains oxygen delivery to the tissues, right? It's a fundamentally important concept in that regard. So you then decide that your patient is unwell and that you have to intubate your patient. So you come along and you've got a nice muscle relaxant, okay? And your patient is puffing away, and they may have a minute ventilation of 26, 27 liters per minute as they are trying to clear off the CO2, and then you go and you now inject the muscle relaxant, right? And what do you think happens? Mm-hmm. Yeah, so your PaO2 has not changed. Your PaO2 has stayed the same. I mean, your PaO2 is not going to go from 60 to 40 in a minute. So that's not what's going to happen. But what's going to happen is that you have taken away the respiratory drive. Your CO2 is going to start rising fairly rapidly. As your CO2 rises fairly rapidly, your saturation is going to go away, right? And your patient is going to have hypoxemic arrest. You have to be very careful about intubating patients that have got respiratory distress. One of the issues that we have in ICU is that intubating patients in ICU is very different from intubation patients in theatre. Theatre is a controlled environment. The patients generally are well. The oxygenation is generally adequate. But in ICU, when you have a tachypneic patient that is compensated to this, then you are going to run into problems if you paralyze the patient. The same thing is that, I think that what we've probably learned from COVID in the past few years is that it is remarkable how much the lung by itself can compensate for hypoxemia. And just by supporting the patient with some high flow nasal oxygen, you are often better off than intubating and ventilating the patient. Because as soon as you intubate the patient and you assume control of the patient's ventilation, problems often start unwinding, unless you're sure that there's a lot of atelectasis. If there's a lot of atelectasis, then it's a different story because you can recruit the atelectatic unit, but often that is not the case. All right. So then the next question which follows in the intubation story is that does hypertension cause hypoxemia? So if your blood pressure is low, does that cause you to become hypoxemic? And the answer to that is it does not, right? I mean, why would low blood pressure cause you to become hypoxemic? So that's mostly true. Yes. But there are some caveats. In physiological conditions, you've got an arterial saturation that you send out about 95%, you get peripheral extraction of oxygen, and your venous saturation comes back at 75%, right? So all that your lung has to do is it has to top up from 75% to 95%. The problem comes is that when you become hypertensive and you're hypoxic, already your saturation of the blood going out may be lower than it is already. You've got poor circulation, you've got increased peripheral extraction, and your venous saturation starts dropping. So now the lung has to now go from 60% to 85%, which is a much greater leap than you had to do before. On top of that, your lung itself is not functioning normally. So we know that a normal healthy lung has got a large margin of increasing its ability to add oxygen to the blood. But as soon as the lung becomes diseased, you lose that ability. So you can't expect the lung to now increase from 60% to 85%. And in these patients here, your saturation becomes proportional to your blood pressure. As the blood pressure starts going down, your saturation starts going down as well, because you're extracting more peripherally, and your lung cannot compensate in this regard. So the take-home message from this is be careful if you are monitoring hyperventilation with hypoxemia. If your patient is breathing room air, then you can stick a pulse oximeter on them, and when they become hypoxic, you can do a gas and see if they are what the CO2 is, if they're becoming apneic. But as soon as you put a nasal cannula on your patient, you cannot monitor it. Many years ago, I was involved with a medical legal case, not my own, fortunately. And the complaint was that the patient had a cervical spine surgery. The patient had bleeding in the neck, and it compressed the back of the trachea. And the assertion by the anesthetic specialist was that the nursing staff had inadequately monitored the patient. You see, and the reason why they had said this is they said if they had monitored the patient carefully, they would have seen the patient becoming hypoxic from the airway compromise, and they would have then alerted somebody, and somebody could have done something about this, evacuated the hematoma, whatever the case may be. But you understand that is a folly. Is that the best word to use here? It's not correct, because the patient was on supplemental oxygen. And if you're on supplemental oxygen, you have to have such profound hyperventilation before you become hypoxemic that it will happen just before the patient arrests, which is what we saw. If you look at the chart, the patient maintained their saturation and then they arrested. So be careful of monitoring hyperventilation by using your saturation. The second take-home message is forget about PaO2. Unless you're working in ICU, where we use it for different reasons, it's a waste of time, it contributes nothing, there's no value to it. And then by inference, if we're not checking the PaO2, there's no value in an arterial blood gas. If you're applying for home oxygen for a patient, then maybe an arterial blood gas, but more than that, stop doing arterial blood gases. The saturation is greatly influenced by your PaCO2 and your acid-base status. And it really is quite remarkable that at a fixed PaO2, that you can have such wild fluctuations in your saturation just based on your CO2 and your acid-base status. And certainly we use this in ICU. So we realize that some patients require a higher minute ventilation if we are stuck. If you can't get oxygen into the patient, one of the strategies that we can use is to increase the minute ventilation, try and get the PaCO2 down so that we can get our saturation up, because we know that the saturation is by far the most important index. And in hypoxemic patients, especially patients with extensive VQ mismatch, you need to keep the blood pressure up. The body can do a low hypoxemia, it can do a low blood pressure, but it cannot do both at the same time. So you need to pick that battle. What your anesthetic colleagues will tell you is that when you have a hypoxemic patient and you're planning to intubate the patient, before you start with that, you put up a central line for the patient, you ask the sister to mix some adrenaline for you, you have it in the pump, you have it connected, you can start a little bit to get the blood pressure up, you do a very gentle sedation of the patient, and then in that way you have a successful intubation. If you are trying to intubate the patient where you give the patient a muscle relaxant, or you give the patient propofol, which is probably the worst thing that you can give a patient in an acute situation, you drop the blood pressure. Now you've got low blood pressure, you've got hypoxemia, and the whole thing unwinds in no time whatsoever for you. All right, that wasn't too hard. Any questions? Yes.
Thanks, Dr. Tilley, for the talk. I'm glad you mentioned the excessive use of the ABGs.
Yeah.
But there may be a caveat to that, and I think maybe something that causes a little contention. In patients in ICU, then, do you feel that every patient admitted to the ICU should have arterial line inserted?
No, we look, I think that A-lines are nice for the nursing staff because they allow blood draws for other reasons. And even for having said that, even for blood gases, we do blood gases often we do venous blood gases, but that still involves, pricking the patient. So arterial lines are nice from that point of view. But I think certainly unless you want to monitor the blood pressure for a patient, then generally we would not place an A-line. And the cutoff usually is the patient is inotrope requiring. So we would tend to stay away from A-lines and non-inotrope requiring patients. You just need your first ischemic hand to put a big damper on your enthusiasm for A-lines. Sometimes it's unavoidable. You have a patient who's on inotropes, the vasoconstricted, it clamps down a bit around the A-line. You do need to check the patient's hand regularly. We've all had our fair shares of ischemic hands, and generally people are not super happy when they come off the ventilator and missing their thumb and first finger. So we must be careful with A-lines.
And maybe from a practical standpoint, obviously maybe worked away from hypoxemia. If you have a hypercapnic patient, then how would you recommend we monitor those patients' resolutions, or COPD patient that comes in? What would you recommend?
So there's a fair amount of work about using venous blood gases and measuring hypercapnic patients, and I think there's general consensus that with a CO2 above 45, up to 45, a VBG will give you the same information. So you can get away with the venous gas in those cases as well. As you know, in ICU, the need to have normal capnia if the patient is otherwise stable is not high. So if you are otherwise stable, we would tolerate a CO2 regardless of what the CO2 is, provided that your pH remains above 7.2. We don't chase the specific CO2 unless you have got other problems. But you know, in COPD in what the patients that you would see are the two main it would be the main thing that one would need to do venous gases on. You know, the pathophysiology of gas exchange in COPD. So you get hypoxaemia and you get a raised hypercapnia, right? And the cause of the hypercapnia is twofold. Firstly, it is the lung that we've spoken about, where you got alveolar dead space, where you get alveoli that are ventilated, all right, but they are not perfused. And you need to think about a COPD patient who has got a poor FEV1, so they are moving very little air to start off with. Your physiological dead space in an average male patient is about 150 moles. Your COPD patient is breathing in maybe 250 moles as a tidal volume. Of that, 150 is off to dead space. So basically, you're putting 100 moles of air into the patient's lungs. Now, if you start knocking off alveoli and you're ventilating alveoli that are not functional, it's not difficult to see how your CO2 goes up. But in addition to that, patients with COPD have a central defect in the respiratory center where they just hyperventilate in and of themselves. So there are two mechanisms for that. Which reminds me, coming back to the pulmonary embolus, how do you get hypoxic in a pulmonary embolus? Does anyone know? So we know that when you occlude the blood vessel, you cut off the alveolus, you get ventilation, but there's no perfusion. We know that cannot cause hypoxemia. What happens though in these patients is that because you've cut off these blood vessels, the blood has to go somewhere else, right? So say for instance, we have the example that I always use is that we know that if we take one lung out, okay, you have a lung operation, we take one lung out, if you're a healthy lung on the other side, your saturation should remain okay. So how is it that if we get a pulmonary embolus to a segment of the left, say the left lower lobe, we get a pulmonary embolus there, how do you become hypoxic? Because we've cut off one bit of lung there. We know that just cutting off the blood supply to the lung in and of itself is not going to cause you to become hypoxemic. The answer is that what needs to happen is that once you've cut off the blood there, it needs to go somewhere else, right? So you are effectively starting to hyperperfuse, right, the other alveolar units. And your alveolar units can increase your cardiac, can cope with an increased flow up to about 3 or 4 times. After that, the alveolar unit becomes overwhelmed and it can't put oxygen into the blood fast enough as the blood travels through it. So you get hyperperfusion of your remaining healthy alveoli, and that's where the problem starts coming in. So, and this has been one of the problems that people have had with thrombolizing patients with pulmonary emboli, because when you have a saddle embolus and there's a mechanical obstruction to blood flow, those patients clearly need thrombolysis. And I don't know if you've ever seen a patient like that, but thrombolysis really is a miraculous treatment in those patients. The problem comes is if you've got a pulmonary embolus that is not hemodynamically compromising, what happens is that you give the patient thrombolysis, you've got this clot sitting there, the clot starts lysing. All of these vasoactive mediators that are contained in the clot starts diffusing throughout the lung, and they start causing vasoconstriction throughout the lung. Even the normal alveolus unit starts vasoconstricting. And then you impede your blood flow through the normal units, and you become hypoxemic from that, because you basically you outstrip the ability of your normal alveoli to cope with the blood flow through them. So the mechanism is very counterintuitive, as one would think. But thrombolizing non-hemodynamically significant pulmonary emboli may not be helping the patient, and that's in fact what the studies have shown us. You may be making things worse for the patient. There's a lot of vasoactive mediators in a blood clot that can become liberated and make your life a misery.
Do you have an idea about the extent of the contribution that reactive hypoxemia-driven pulmonary arterial vasoconstriction can add to the hypoxemic event? And in second part to that is that why why don't we use inhaled nitric oxide or prostaglandins more often, in particular the PE patients?
Well, the easy answer to that is that it's difficult and expensive. All right. So I don't. So you generally need to be. You generally need to. I mean, I suppose you can give somebody who's not ventilated nitric oxide. I suppose it's possible. I mean, most of the patients that we do are ventilated. The cost is exorbitant, and that's probably the answer. There's no doubt that if you've got a patient who's got VQ mismatch and you give them nitric oxide, that the oxygenation will improve, right? Provided that there are sufficient healthy alveolar units left. The problem when you become hypoxemic is not vasoconstriction; it's the lack of vasoconstriction. Okay, because the problem is that if you vasoconstrict the areas where the lung is not functioning, all that will happen is the blood will get diverted to the remaining healthy lung, and you won't be hypoxemic because the healthy lung will take over whatever is happening there. What happens is when you get a pneumonia or you get a pulmonary embolus or whatever the case may be, or pulmonary is not a good situation, but if you get whatever fills your alveolus up, you don't get vasoconstriction there, right? Because vasoconstriction would be the sane physiological compensation to stop blood flowing through an area where there's no air. But as soon as that happens, you get vasodilatation of the area, paradoxically. So you get increased flow of blood through this area of the lung where there is no air, and you make it worse. And the question is, how can you solve that? So you can solve that in one of two ways. You can try and vasoconstrict that part of the lung, right? And I don't think we've got a way of doing that. Or you can try and vasodilate the rest of the lung, okay, to try and decrease the resistance of flow so the blood flows easier through the rest of the lung and preferentially then goes that way. And that would be the purpose of nitric oxide. I mean, we've used nitric oxide a few times. The oxygen comes up, the patient still dies, unfortunately, because the reality is that when you get to a situation where things are like that, you're in a tremendous amount of trouble. One of the uses of lactators as well is that I think that especially post-COVID, we have become a lot more tolerant of hypoxemia. In 2018, if we did what we are doing now, I think that it would have been very frightening. But we tolerate hypoxemia a lot more than we did back then. And we can use lactate as a surrogate marker. If you've got a patient who's hypoxemic and the lactate is 0.8, 0.1, 1.5, you could relax. Things are okay. The body is happy with the situation. You are having adequate tissue perfusion. Things are fine. If you start seeing the lactate starts going up, and if you start getting above 3, you're in trouble. That you need to start taking action there. So you can assess it in a patient in and of itself. If you've got a granny who's got SATs of 85%, the work of breathing is not excessive, the lactate is 1.6, then let granny have a SATs of 85%. Don't chase a number specifically.
The point of care lactate machines?
I don't know. No, the lactate will come off the gas machine. If I can give you one piece of advice, is to install an ABG machine at your point of care. An ABG machine will really, the information you get off it is invaluable. You can see a hemoglobin, you can see basic electrolytes, you can see a lactate. It is really if you want to triage a patient in medicine, it is by far the best things. It's also of use. I mean, lactate is just such a useful thing. Lactate goes up in seizures, right? So you have a patient. You see patients with pseudo seizures? No. It's a very common thing in private. Young people come in having seizures. And they're not having a seizure. They know they're not having a seizure, but now we have to prove it to each other. So the lactate, actually, if you start looking at lactate during seizures, it actually becomes quite frightening. We get lactates up to 12, 13, 14 during a patient with a grand mal seizure. If a patient says that they're fitting in front of you and you do a blood gas and the lactate is 0.8, well, the chances are not high. Lactate is great for bleeding as well. So if you've got a patient and you you suspect the patient is bleeding, the lactate will start going up long before the patient becomes hypotensive. It really is always remarkable to me how much bleeding can hike your lactate. So, a patient comes in, they've got abdominal pain, you're not sure what is going on, is there ischemic bowel or they're bleeding, whatever the case may be, you do a gas, the lactate is 0.8. It's very reassuring with the whole situation. So it's such a useful test. I think it's not done often enough, but don't do an arterial stab for it. Any other questions?
I suppose the patient with subclinical seizures will also have.
Yeah, but I mean, really, what is this? It's you when you go out and you start seeing, you see that there's a phenotype. All right.
We had a patient like that. So
Yes.
she says dropped like suddenly.
No,
She
yeah.
wasn't fully controlled anyway.
Yes.
So, but clinically, like you wouldn't see her having seizures.
Yes.
We find another reason why.
No, that's a different situation. No, that's a different situation. If you are doing a call in private, in 12 hours, you are guaranteed to get one young person with seizures. Yeah. So, and I'm not saying that if the lactate is normal, ignore the patient, but if the lactate is 11, you must take it seriously. Then there's something going on with the patient. Then you know that they are very likely are fitting. You can check his CK as well if you want, but the lactate will do the same job. And then it's also prolactin that goes up after a seizure, but a gas will tell you within seconds, where you want to be. Any other questions?
Just like all the practical questions. So
Sure.
you said avoid intubating or beware of intubating patients with these high they fractured neck and
Sure.
compensate in that. But I mean, eventually those patients are going to rest.
No, I'm not saying that you mustn't. Well, they may or may not. So to answer your question in a roundabout way, is one of the things that we need to be able to determine is when is the patient not coping with the situation. So when do we need to intubate them? That's a very difficult question to answer. My advice for you there is twofold. Firstly, the respiratory rate is your friend in that regard. If you've got a patient who has got a respiratory rate up to 25, 26, you can generally be assured that things are okay. Patients can cope with that. When your respiratory rate starts going above 26, especially above 30, your work of breathing becomes excessive. And you can predict that a patient who's got a respiratory rate above 30 will require mechanical support just from fatigue in the near future. So the respiratory rate is really a great way to monitor those patients. And the second one is then your CO2 will start turning, right? Because in most tachypneic patients, your CO2 should be normal to low, all right? And when your CO2 starts going up, that's when you need to worry. I mean, the typical case is an asthmatic patient. So an asthma patient who becomes normocapnic or hypercapnic, that's when you know the arrest is imminent. I'm not saying that you mustn't intubate these patients. If there's a need to intubate the patient, you can intubate the patient, but you need to be prepared for the situation. You need to understand that once you have altered the physiology of the patient post-intubation, that the situation may shift fairly rapidly. And that if you've intubated a patient and you've taken them from a respiratory rate of 40 down to 10, okay, you must not be surprised that your saturation disappears. That is to be expected. There's no other way around it. And that's why you must be prepared that you have inotropes ready so that you don't become hypotensive at the same time. Because if you intubate a patient, you drop the respiratory rate, you make them hypoxemic, and then they drop their pressures, that's the end. Then they're dead.
Sorry, I have one more, just
Sure.
because I'm asthmatic. So when I work in ED privates, they told us that we should have like a high threshold to intubate asthmatic patients.
Yes, I would go as far as to say that as far as you are concerned, if you're not an intensivist, you should not be intubating asthmatic patients. There is nothing as frightening as an asthmatic patient on a ventilator. It is an absolute nightmare beyond what one wants to cope with. So, if you start thinking that, asthmatics are difficult, it's always difficult to know when you get into trouble. Probably the CO2 is your best indicator there. If your CO2 starts coming normal or high, then you know you're in trouble. But in those cases, really you ask for somebody to help. It is a nightmare, because the positive pressure ventilation cannot fix obstruction. So you just make it worse. And it really is difficult to ventilate that patient. There's interestingly enough, there's more and more work now on using non-invasive ventilation in asthmatic patients to help with their work of breathing. And that seems to be a useful modality, but still you need to be careful so that you don't miss the opportunity. But I think asthmaticus as a cause of respiratory failure is a very niche topic. We don't see that much anymore, though. I mean, when last did you see? I don't know, maybe you do, but we don't see severe asthmatics that much. It seems to sort of have gone away a bit. I mean, I don't know, maybe it's just if you take your puffers, it's not that bad anymore. I must say it's been a long time since we've seen in private, and then essentially when they phone, then I suggest somebody else normally.
Scary if you don't see it that often.
It is scary, and the last one we had to manually decompress the chest. I don't know, it was just a very unpleasant experience. Most patients, if you nebulize them, you can give them some magnesium, some steroids will settle down, in time. Asthma has got the runoff from an asthmatic attack is usually the same time as a run up to the asthmatic attack. So if you've got an asthmatic patient who's been uncontrolled, for months, just getting worse, slowly, those are the ones that really get you into trouble, because they take a long time to get better. Whereas the patients that, are fine and then have an acute event, they normally settle down just as rapidly. Hello, how are you, Ishmael? No, but there is value. Yeah, there certainly is. The capnography is I mean, the anesthetists are more keen on it. The issues with it are, I think, mainly cost. Yeah, absolutely. No, there should be value in that as well. Absolutely. Anything else? All right. Thank you. Bye-bye.